All right, hello everyone, and thank you for joining us. I'm Jessie Bengoa with Platinum Performance, and today I'm here with the group, an all-star lineup of veterinarians who are among the leading authority figures in laminitis, which is our subject today. I recently had the pleasure of working with each of these veterinarians on an article detailing laminitis, which is, as I'm sure most of you know, one of the most devastating equine conditions and also one of the most frustrating to treat. And we'll get into that in just a little bit. Today, we want to bring that article to life for you in a roundtable discussion that will hopefully provide a deep insight into laminitis, its causes, treatments, and perhaps most importantly, preventive measures that can be taken to hopefully avoid this condition altogether. So let me introduce you to the veterinarians joining me today and give you a window into their expertise. With me, I have first up, Dr. Steve O'Grady of Virginia Therapeutic Farriery. Hello, Dr. O'Grady.
Hi, Jessie.
Dr. O'Grady, he's a world-renowned veterinarian. I get to say this about him. He'll roll his eyes. And he's an expert farrier whose, really his life's work has been centered on understanding and treating laminitis. Also with us, we have Dr. Andy Parks. Hello, Dr. Parks.
Good evening.
Dr. Parks is many things, but among those, he's a department head and professor at the University of Georgia's College of Veterinary Medicine, and he's really amassed an incredible body of work on laminitis throughout his career from both a research and clinical perspective. And next up, we have Dr. Mark Silverman of Sporthorse Veterinary Services in Southern California, not far from where I'm sitting. So hello, Dr. Silverman.
Good afternoon. Good to see you.
Good to see you as well. So Dr. Silverman, he's a highly respected sport horse veterinarian. He's a skilled farrier. He's also a former dressage trainer, and the list goes on. Dr. Silverman has a tremendous amount of clinical experience in treating horses with this condition. And I'm so happy to have him here with us today. Welcome, Dr. Silverman.
Thank you.
And last but most certainly not least, we've got Dr. Craig Lesser, who's joining us from the famed Rood Riddle Equine Hospital's Podiatry Center in Lexington, Kentucky, where he's both a veterinarian and a certified farrier. Dr. Lesser and his colleagues at the Podiatry Center, which includes Drs. Raul Bross, Scott Morrison, Scott Fleming, they see a large number of laminitis cases and have quite a lot of clinical experience in the condition. So welcome, Dr. Lesser. Okay, so that's our dream team for today. And let's go ahead and dive right into it so they can share what they know and we can come away with a more solid understanding of laminitis, the diagnostics, treatments, therapeutic farriery, and ongoing management practices involved in this condition. And also learn how to best prevent it, which would be numero uno here. Dr. Silverman, lucky number one. If you would, can you take us through the anatomical structure of the hoof and kind of acquaint us with the players involved that we'll be mentioning throughout the rest of this talk today? We've got the P3, which has about 5 different names, I'm learning, the lamellae, the deep digital flexor tendon, and the list goes on. Can you paint a picture for us of what the hoof structure looks like and how it all comes together in relation to this condition?
It's similar to your finger, or the end of your finger in some ways. You've got a bone structure internally. You've got a P3 or a coffin bone, the two most common names for it, that is housed within the hoof capsule, which is a semi-rigid structure that protects and connects the horse to the ground. The biggest significant point of this is that the coffin bone, using that term, is suspended within the hoof capsule, not supported by the hoof capsule. It's not a bone stuck into an ashtray. It's actually a bone that is hung from the inside wall of the hoof capsule. And that's accomplished by a very complex soft tissue system called the laminae or lamella that has a very an enormous surface area and blood supply and nervous supply that surrounds the coffin bone. And I like to use the term living Velcro. So if you picture the coffin bone suspended or hung up within the hoof capsule by the walls of the hoof capsule, not so much supported by the bottom of the sole and the frog, that'll be a key understanding to working down the road to understanding this disease and what goes wrong and what happens when things go wrong. So theoretically, you could peel away the bottom of the foot, the frog and the sole, and the coffin bone would stay in place. A failure or partial failure of that Velcro.
Dr. O'Grady, I'm going to turn to you next, and we'll take Dr. Silverman's comments and kind of zero in on the hoof capsule. You've described treating laminitis as treating a disease in a box, and that quote kind of stuck with me after this article. And that's because of the challenges that the hoof capsule presents as a rigid structure. So kind of walk us through that, if you would.
I like to think about treating the tissue that causes laminitis as a tissue that's locked in a box. You can't see it, you can't feel it, it's hard to treat because it's enclosed in this structure, and it's quite hard to monitor. Even the imaging part will present some problems because it's inside a structure. If we go a step further and think about the lamellae as a soft tissue structure, it's enclosed, and we think about the box, it's enclosed within a rigid hoof capsule, or a rigid structure, the hoof capsule. It accepts tremendous load. It has the weight of the horse on top of it. It's subject to the different biomechanical forces, both when the horse is standing still and when it's in motion. And if we think about the start off, before we have a disease, we already have an inadequate circulation in the dorsal section of the horse's foot. So these all present a big problem.
Excellent. Thank you for that description. And, you know, Dr. Parks, I'm going to turn to you now. There are factors of this disease that really are universal, and that's things like the inflammatory component, some presence of potential ischemia, and varying degrees of displacement. So can you walk us through these factors and also detail the various forms of displacement that can occur and the challenges that each of those present?
So I'll do my best. And Mark has pretty concisely described the end point. Okay, so what's well known is that there's, multiple pathways in. So the obvious ones are, sepsis related, endocrinopathy related, road founder or straight trauma, and supporting limb laminitis. So we have these four pathways in that all have a sort of a similar endpoint, in which it is basically the disruption of the lamellae or the Velcro. And at what point do those paths merge to become common? I will have to correct a little bit, and that is my experience is almost entirely clinical, but I have great friends who are researchers on the subject, and they keep me as best informed as possible. And for example, we actually know now that the endocrinopathic entry into this disease is different to the sepsis, and that there is obvious expression of cytokines and lamellae in the sepsis-induced disease, and that is not quite the same in the endocrinopathic entryway. So the next point to make is yes, so we have four entry points. We have a common endpoint, which is disruption of the lamellae. But then there's another sort of a split, and this is where we know even less. And there's a split into not all horses damage the lamellae around the circumference of the hoof in the same manner. So this gives rise to different patterns of displacement. And in fact, different, sometimes the forelimbs are affected, sometimes all four limbs are affected, and occasionally just the hind limbs. So you get these different patterns of displacement, and they must be associated with a different distribution of damage. And honestly, we're learning. But there is quite a lot of significance behind that. Steve referenced treating something in a box. And when the lamellae are starting to displace, you don't know what pattern of displacement is going to occur, because you can't see with regular x-rays or with clinical tools, you can't see. With MRI, you probably could, but people don't do that routinely. But you can't see the pattern of displacement. So from a clinician's point of view, you're hoping it won't displace, but if it is going to displace, you'd like to know the pattern that's going to occur, because you'd like to treat it correctly, and they each benefit from slightly different manifestations of similar treatments. So it's complicated and there's a lot to learn.
I think that was the primary thing I took away from the article on this subject is it's complicated and we have a lot to learn. So thank you for that. And Dr. O'Grady, I'm going to turn to you next. And, you know, I have a question about the rotation that you can sometimes see in cases versus if you've got a sinker or things along those lines. I learned quite a bit, you know, writing this article that I didn't know about that. So if you can take us through those two different factors and kind of describe the challenges that come with each one of those cases.
Absolutely. If we divide the situations that you're talking about, if we start with what we call a sinkhole sinker or distal displacement of the distal phalanx, that is probably the worst scenario of the types of displacement of the bone. And what happens is there, for whatever causes this particular entity, affects the circumferential lamellae all the way around the bone. So instead of rotation or displacement to one side, the bone sinks down within the horse's foot. One of the biggest problems we have here is that we don't have, let me back up just a little bit. As we have this distal displacement, what happens at the coronary band, those usual papillae that are straight, they start to bend in almost a horseshoe shape. So in order to rehabilitate any of these cases, you need to grow good hoof wall. And there's been a lot of different things tried with these ablations and grooving and whatever. At this point, we really don't have a way to get those papillae growing straight again, which is the biggest problem. The second thing is, when the weight of the horse pushes the bone down in the hoof capsule, the deep digital flexor tendon is not involved. So in some of these severe cases, you know, we can turn to a tenotomy. With the horses that sink, the tenotomy is really not that effective because you don't have that much influence, you know, on the distal phalanx. And if you do a tenotomy on these cases, it will give them a little bit of relief for a period of time, but you can almost count to the day with 6 to 8 weeks, that tendon will kind of reattach or you know, form an attachment, and it'll contract and you'll be worse off than you were before. As far as rotation goes, with rotation, what we have there is displacement of the bone in a distal direction caused by the compromised lamellae on one side and the deep digital flexor pulling it on the other way. In other words, pulling it from the other direction, and you have the weight of the horse. Sometimes when we describe this, we don't talk about the weight of the horse pushing this down. And then again, as far as the compromised lamellae goes, the amount of the damaged tissue is going to be correlated to the amount of rotation or the damage you have that way. Horses that displace unilaterally, in other words, to one side, usually to the medial side, is something that we've been recognizing more recently. And what happens here is that usually it will be combined with dorsal capsular rotation, and usually with a horse. I haven't seen it, we've treated a lot, and I haven't seen any of them that don't have a foot that is offset to one side, which means you have more weight bearing on the medial or the affected side. Therefore, if you have laminitis affecting the dorsal part of the foot, this kind of foot can also go ahead and displace to the medial or the inside. We have been fairly successful treating these horses with unilateral displacement if we get to them early. And that's not a very high percentage. And if they rupture at the coronary band, I haven't had any success treating these things once they've opened at the coronary band. Maybe others in the panel have.
Excellent. Thank you for that. I appreciate it. So moving on, Dr. Parks touched on this a bit, that there are 4 causes of laminitis, but 3 primary causes that we discussed in the article. And I want to kind of dive into those so we can take them one by one. And a lot of the credit on identifying and some work done on these 3 main causes goes to Dr. Kathy McGowan's group at the University of Liverpool. And although there are even more causes that we could probably add to the list, those 3 main ones are recognized as sepsis-related, endocrinopathic, that just rolls off the tongue, or metabolically related laminitis, and then also support limb or contralateral limb laminitis. And each of these avenues into the disease state is so unique in a lot of ways, but it also shares a lot of commonalities in the pathophysiology and really that telltale damage that's done to the inside structure of the hoof. And Dr. Lesser, I wanted to go to you first and tackle the first of these primary causes, which would be sepsis-related laminitis. So can you tell me about this form of laminitis, some of its triggers, and also some of the things that you're doing and considering when you're confronted with a case head-on?
Yeah, for sure. So, a lot of these cases are from pneumonias that have had a septic shower, colitis, whether it's post-op colics, whether it's Potomac horse fever, diarrhea related, and a variety of other causes that form a septic shower. And similar to what you're seeing on your gums of these horses, the terminal papillae receive this septic shower, and that can cause a lot of damage and the breakdown, inflammation of this lamina. Like Dr. Parks had said earlier, there's a lot about this we don't know. And the research is, thankfully, there's a lot of money going into the research. So we're constantly learning new things about these different forms of laminitis, but there's still a lot we don't know. So we start with treating the underlying cause. So luckily I get to work with a lot of medicine people when dealing with septic related cases. And if they can't get the cause of the sepsis under control, it makes it very difficult to get the horse more comfortable on their feet because we continue to receive this septic shower. But once they get that under control, before they get under control, usually what we're starting with primarily is cryotherapy. Cryotherapy, I believe there's an article out saying that horses started in cryotherapy immediately were 10 times less likely to develop laminitis, at least clinical laminitis. I think there's a lot of horses that we don't diagnose because they're subclinical, and there are some small changes that we don't see because they aren't showing enough pain and inflammation. But they're definitely going through some of these same changes. So, the first thing is getting the disease under control. Then we're going ahead and we're supporting the foot, one with our cryotherapy. We spend a lot of time on shoeing mechanics to prevent those inflamed lamina from continuing to break down, and then anti-inflammatories to keep the process under control.
Excellent. Thank you for that. And, I'm going to shift gears just a little bit. I was going to ask about cryotherapy later on, but since you brought it up, let's go ahead and do that now. And Dr. O'Grady, I'm going to toss it back to you for this one. And can you kind of describe where we're at in terms of cryotherapy? It really needs to be done a specific way to be effective, correct? And it's most effective within a certain time frame. So if you can take us through that. I remember when I interviewed you for the article, you were cracking me up because you said, listen, if you don't get the slurry just right, don't throw ice cubes in a bag. You might as well put that ice in your drink. It's not going to work. So anyway, take us through that if you would.
Yeah, it's kind of interesting. On Wednesday afternoon, I was talking to Dr. Chris Pollock in Australia. I did a webinar the other night, and him and Van Epps have done most of the work in this recently. For years, we thought that it was just useful in the developmental stage of the disease. In other words, before the horse showed acute signs, and then they have done enough work where they've shown it's been very effective in the acute stage in a lot of horses. Okay, what they feel is that to administer this properly, it needs to be, and people will put ice bags around their feet, or they'll put them in a little swimming pool or whatever, And what they really need is that the ice or the cold therapy, ice therapy, has to extend above the fetlock and preferably to just below the hock or the carpus to be effective. Number two, it needs to be in an ice slurry. In other words, get your ice together and then put some water in it. And when you think about it, when it circulates around the limb, you get this diffuse effect where you're getting the cold to all the areas there. But one of the biggest things, again, that you need to have the therapy above the fetlock. In other words, those digital arteries and up higher. The other thing that Chris stressed, Dr. Powell stressed the other night, was that when you see a horse that in the acute stage, in other words, when he's first diagnosed, it is only really beneficial for the first 36, 48 hours in the acute stage. And if you're going to administer ice, he feels that it needs to be continuously done. And, you know, you can put different types of appliances or whatever you're going to do to the feet where they can stand in the ice. But he feels that it should be continuous, you know, 24 hours a day for the first 36, 48 hours.
Can I just butt in and say something about follow up what Steve said?
Of course you can.
Just from a practical point of view, using crushed ice is much better than cubed ice, which is a little basic thing that slips past people. And the most important thing is that it's the water that surrounds the foot that is important rather than the ice, because you know, you need to be between 0 and 5 degrees C if you can get it. But people forget. People just think because they're putting ice in there, it's going to be at 0. People forget that you can have an ice cube at minus 20 degrees Celsius. And if you put minus 20 degrees Celsius ice cubes against the skin for a long time, they will get frostbite. So it's important that it is a slurry. It's easiest to make the slurry with a crushed ice. And don't forget that ice alone can be a lot colder than 0 degrees Celsius.
God, what a great point. Thanks for jumping in with that, Dr. Parks. Dr. Silverman, now back to you with cause number 2. So following up on sepsis-related laminitis, let's turn to endocrinopathic or metabolically related laminitis. This one's by far the most prevalent cause of the disease, correct me if I'm wrong. And it's such a major frustration because in so many instances, it's also the most preventable cause of laminitis. So detail this type of laminitis for us, if you would, and the risk factors that you're looking out for as a veterinarian, even before these cases necessarily become clinical.
Well, there are two interesting aspects of the metabolically related laminitis. One of them is probably the most predictable, because you can see the horses that are predisposed to this. You can see the characteristics of the fat distribution. You can see the body type that predisposes to this kind of thing. And a probably greater complexity from a treatment standpoint is that the insult lives with the horse. It isn't like they got out and ran down the road and traumatized their feet at one moment in time. Then you go back there and deal with the aftermath, and you don't have the insult anymore. In this case, they have the insult up front. You can almost predict they're going to have a problem. They have the problem. Then you're dealing with the complex mechanics of the problem, the medical support of the problem, and the fact the problem is still poking. It's like, poke, poke, I'm still here, which makes it challenging. And from our veterinary standpoint, the most frustrating part is that we create it. We overfeed these horses, we undermanage them in some cases, or we overmanage them, I guess, is another way of looking at it. But we think we're rocket scientists, nutritionists on these horses. And sometimes we overcomplicate what we give these horses and duplicate support nutraceuticals that they don't need. And we like them, like in my industry, I'm more of a dressage guy than anything else. We like the horses a little full-figured. They're heavily muscled horses, but we like them to look full and strong. And as I point out in the article, sometimes that cresty neck is just that. It's a cresty neck. It's not a stallion neck or a Grand Prix dressage horse's neck. Although we get to a point where we expect a dressage horse to have that appearance, the great riders and trainers and horses earn that appearance through massive musculature. A lot of it is just like the look of that horse and to get there another way by feeding. As far as the insult, the metabolic diseases, whether it be insulin resistance or Cushing's or EMS of the general form, there are trigger factors that affect specifically the tissues within the foot and trigger this gradual decline of strength and support in the foot. The disease, I find a lot of times, this disease in these horses comes on gradually. You'll see horses that have changes in the hoof capsule, changes in the conformation of the foot that could tell you they're heading in a bad direction before they actually get painful. So you have a chance to go in there and change how they're supported and change their diet and maybe change their nutraceutical support to avoid a crashing. I had a case recently where I had tested a horse with Cushing's and ran into a problem with the owner wanting me to treat the horse because the horse was just fine. And then a year and a half down the road, predictably, the horse did founder in one foot, and now we're dealing with that. So that's the frustration of the metabolic kind of condition, is we can often avoid it, but we don't always see that far in advance.
Yeah, I like that. And, you know, I remember when we talked for the article, I remember you saying, you know, as a veterinarian, wait and see is never the right approach to take, that you really try and be proactive about making sure you're commenting on these horses' body conditions or on these Rubenesque, because you call them body conditions out there, and intervening early enough because that subclinical state is so important. I remember you saying that most of the damage to the feet occurs before a horse is painful, and that once they're painful or symptomatic, you're past the developmental phase and there's likely been basement membrane damage done.
And then you're pushing a pebble uphill with your nose.
Right.
Yeah.
Which is always fun. Yeah.
always fun. And the other thing is, in a lot of, other than Cushing's, which has direct medical treatment for as far as, you know, pergolide and other things, a lot of the treatment aspect of these horses is diet and exercise. And diet we can control. But once they're like this, once they're painful, exercise is a difficult thing to achieve unless you have access to water treadmills and other things where we can decrease their net weight and have them exercise. So half of your tools are not usable. So it's very challenging and very frustrating when you get to these cases where you get to them too late.
Yeah, I hear you. It's not a position that you want to be in, completely understandably. Dr. O'Grady, right back at you. I'll turn to you now to give us a glimpse of the third of the primary causes of laminitis, and that's support limb or contralateral limb laminitis. Walk us through what's occurring in these cases and the element of the unknown that still exists in identifying concrete triggers. You know, I know you and I talked for the article about some pretty famous cases that have taken place, and you're saying, you know, that horse wasn't necessarily standing on, you know, putting weight off of its injured foot onto its good foot. You know, it had everything working for it and it still developed laminitis. Go figure. Why? Take us through that cause of laminitis and kind of the unknown factors there, if you would.
Yeah, I think we're questioning that a little bit more as time goes on. And Dr. Parks and Dr. Lesser, they might have some input here because they both work in a hospital situation. But I can remember ever since I started that when a horse, you know, came down with laminitis on one limb or contralateral limb laminitis, it was always blamed on oxygen deprivation. In other words, that there was, you know, there was no circulation to the tissue. However, when you think about it, just think about, you know, in your everyday life, you know, that as an ambulatory clinician or the farms you visit, how many horses do you see that have an abscess and they're holding that leg up for 10 days, 10, 12, 14 days, and then the abscess ruptures at the coronary band? They say, you know, wow, that feels good, and they go on about their business. Or any serious disease, a nail puncture, or something that's going to cause pain in the foot where they show a marked severe lameness. Once you alleviate that, the majority of cases are going to go about their business. Now, that famous horse you were talking about, Barbaro, the few times that I visited him post-cert, well, even in the video, when Dr. Richardson finished the video, in the recovery room, saw that horse standing on the operated limb and holding the other limb or resting the other limb. The few times that I visited him, I saw the same exact thing. He was standing until it got infected. He was standing on the operated limb, and he would be it would be resting the contralateral limb. And I even went to the interns, and I asked them, I said, when you monitor this horse, how's he usually standing? He said, usually just like that on the operated limb. Yet 3 weeks later, the horse came down with severe contralimb laminitis on the other side, before, and then it deteriorated into the front feet as well until the horse was finally lost. So the bottom line is, that we really don't know. And in your question, you talked about the pump, and there's so much controversy about that. And as far as we know now, the frog is not responsible for pumping blood up the leg, as farriers may think, or the lay people may think. Is what appears to happen is that the hemodynamic system in the horse's foot, when the horse lifts takes weight off his foot, these vessels will fill with blood. And then when you turn around and the horse puts weight on his foot, the veins have no valves in them. So the weight of the horse pushes the blood back toward the heart. So I guess until we're proven wrong, that's probably our line of thinking right now.
Okay, well, I was hoping that you would comment on that part. Good. No, I think it makes perfect sense. And yes, Barbara was the case I was referring to. And it's just, it's interesting, it's sad, it's something that, hopefully with more research in the future, we can get a better handle on. Dr. Silverman, I'm going to follow up to that question with you. And that's, we know that time is really of the essence, like so many conditions with horses. It's of the essence in laminitis cases, but in support limb cases, you really want these horses to be healing the primary injury as quickly and as thoroughly as possible to help alleviate any additional risk of that contralateral limb bearing too much of the weight and kind of tipping into a laminitic state. What are some of the tools that you're using to support healing? Obviously in our world, it's advanced nutrition, but walk us through what's going through your mind and what you're using.
Well, as you point out, having the other systems of the horse working at optimal levels is very important. So as far as their feeding and digestion, you have to optimize that. Otherwise, some of the medications we use orally aren't going to get the job done because the system is not appreciating what's being done for it. That's one. Two, controlling the inciting cause. What triggered this whole thing in the first place? Whether it be support limb or other causes, you have to arrest that process as best you can. If you're worried about support limb or anything where you're trying to prevent an occurrence, trying to unload the walls and primarily load the core of the foot is something we do a lot of, trying to not have the core of the foot plunge down through the hoof capsule. So the support methods we use, the mechanics we use, whether it be a clog or a fancy shoe or appliance that we built for the horse, decreasing the pull of the digital flexor tendon is often part of this game with wedge shoes of some method. Again, the clog or other dozens of other ways of doing it. Let's see what else. I think to a point, pain management is important. I don't think we want to manage them to a point where they don't feel pain. We need to have them protect themselves when they have pain, but we also need to have them use their body a little bit to try to protect one limb from taking too much of a pounding. Trying to think of what else we might have there. General nutrition, mechanical support, arresting the cause. These are the primary things. Circulatory changes. We'll do things with rheologic agents to try to optimize circulation and growth factors and other healing factors to the feet if there's a disease state going on. And from there you can get fancy. You can get into all kinds of fancy support systems and slings and transfixational braces where you actually take the foot off the ground. Depends on where you are and what the horse is and how far you want to take it.
Excellent. Well, we love it when you get fancy. So thank you very much for that.
Yes, could I say another word?
Of course you can. Go ahead.
Going back to the contralimb laminitis, I think it's seen and described more in a hospital environment than it is out on the road or out on the farm. Most of those horses in a hospital environment, they've suffered a traumatic injury. They've gone under surgery or other kinds of treatment. And then the various medications, the stress of being in the hospital, the fluids, the medications, whatever. And we don't really know what stress is. It's very hard to define it, but I think it really plays a role in disease. So I think that the stress of being in the hospital environment may have something to do with these horses that are going to come down with contralimb laminitis versus the ones out in the field.
It would make so much sense. You know, you think about human medicine and what stress is a cause of, and it would make a lot of sense. So
Yeah.
thank you for that addition.
If I can add in this one more detail right along those lines, one factor is with these multifactorial disease states is there's a generalized inflammation, and that kind of inflammation actually affects the function of the blood itself, affects the viscosity of the blood itself. There's been some work done with trying to normalize the viscosity of the blood to avoid this disease state. So there's a lot of really hard to grasp factors involved here as well.
Oh my goodness. Like everything, this condition is definitely one of complication, and there's so many factors of it. So thank you for offering that up. And, you know, I want to turn to Dr. Lesser for a moment and take a few steps back, because really acute versus chronic cases can be very different with laminitis. And one thing I learned from talking to you all is how quickly an acute case can be classified as chronic. And Dr. Lesser, if you would take us through kind of the difference and when that acute case can become chronic, when that scale is tipped, and then also when these cases are in front of you and you see them coming into Rood and Riddle, what are the initial things that you're taking into consideration to start assessing the patient and deciding what avenue you're going to go forward with?
Yeah, so I guess I'll start with my assessment first, and I really do like to just sort of take a step back and observe the horse initially, you know, see how often they're shifting back and forth. I know there was a research paper done that a student watched a horse shift weight back and forth for an hour to see how many times they shifted their weight, and there's a normal for horses. So knowing what that is, you know, looking at your oval scoring, there's a 4-point scoring system that we can use. Your grade ones, the horses are walking normal, but they're shifting weight and they're trotting a little bit shortened versus your grade 2, which you're going to start noticing it at the walk. The horse will kind of resist lifting the foot up off the ground a little bit, but we'll do it. And then your grade 3s, the horse is very reluctant to lifting each individual leg. And then your grade 4s, where the horses are oftentimes recumbent completely. So, you know, that, and then I'm looking at our growth rings on our hoof wall. So I'm looking if there's any divergence. So is there wider growth rings of the heel versus the toe? And then also inside versus outside. Is there a divergence medial to lateral of my growth rings? And then I start my palpations from there. Digital pulses are always important. You know, if you're not seeing a lot of these, compare the fronts to the hinds, because oftentimes if it's just affecting the front limbs, your pulses in the fronts will be different than your pulses behind. And for me, actually, the most useful palpation is palpating the coronary bands. I've noticed a lot of horses, by palpating the coronary bands, you'll start noticing changes in your coronary bands before you start noticing major changes on your radiographs. And also, one of the other things is you're going to pick up subtle sinkers, medial lateral sinkers, by palpating your coronary bands. I think a lot of horses do slightly list medial to laterally, just like Dr. O'Grady was saying, because of their conformation and how they're weight bearing. Some of these horses that are rotational also slightly list medial to laterally, and that kind of affects how we're going to treat these horses going forward. And then hoof testers are a huge part of my plan, just to figure out what can bear weight, you know, because that's a lot of what we do is we take the load away from structures that are painful and put the load onto structures that can handle it. So that I do all of that before we're even looking at doing any true diagnostic tools. I radiograph all of these horses with 2 views of every foot. And then that's kind of where my initial plan stops. Then pending what the horse is, how difficult the case is, whether it's been refractory to other treatments. I do use venograms occasionally. There's 2 separate camps, some that think venograms are bad, some that think venograms are necessary. I'm definitely kind of a middle of the road person, that I use them as a tool in my toolbox, especially on some difficult cases that we might not be having the results we were expecting initially from. Our acute versus chronic, our main treatment is mechanics. So yes, we are going to treat them differently, but mechanically, it's very important to address the mechanics of both of them. My acute cases, we're hitting these a lot harder with anti-inflammatories to get everything under control. I think a lot of these horses are subacute for a long period of time before they become acute, because you're seeing some bone changes. You're seeing these horses are chronically thin-soled that, I get this, this horse is always sore after he's trimmed, and then he comes in and he's acutely laminitic. It's like, well, actually, I think he's probably been subacute for a few years, and he's just finally going through this acute phase. And then chronic, and there's the chronic that's truly chronic, they're just sore all the time, and there's the acute on chronics, where some of these, especially these endocrinopathic ones, have been chronic laminitis for years that we've been managing well, and then they go through these flare-ups at times. So, it gets very complicated when you start getting into categorizing them. But I think the core of it all comes back to, where can we load these, and mechanically, how can we support this limb better?
Excellent. Thank you so much for that. And Dr. Parks, I want to just do a quick seg over to you real quick, because Dr. Lesser mentioned the 2 views and the radiographs, and that wasn't always the case, right? That's been something that's been a development where it moved from 1 view to now doing DPs and lateral.
Well, that depends on how far you want to go back.
Okay. I remember you telling me some of the history before the article, and that was kind of an advancement, right?
But one thing I'd like to say something else quickly before that, and it is to follow up on something that Craig said about palpating the coronary band, because rotation is, as a sequel to laminitis, been known for a very long time. But in the early to mid 80s, Gary Baxter reported the first cases I remember seeing in the literature of horses that were sinking. And the interesting thing is, if my memory is correct, 8 out of those 12 cases had palpable changes at the coronary band without radiographic evidence of change. So the coronary band can steer you. Okay, and those of us who've been around a little bit, as an intern and a student and a house officer, I was taught to take lateral radiographs for laminitic horses' feet, and sometimes you took 45-degree obliques to see if there was any damage to the rim of the distal phalanx, and I never really got very much out of that 45-degree oblique. And then somewhere, I'm sure there was this is a case of parallel evolution, but somewhere in the mid-90s, I for one started radiographing DPs on laminitic horses and abandoning the 45-degree oblique, more or less. And I think that's because nobody really recognized asymmetrical or medial sinking as a separate entity. But it's really hard to diagnose without a DP. Even on you've got to be careful diagnosing it on a DP anyway, because a horse can shift its weight and start to fake some changes in the distal limb. But yeah, so I'd say somewhere between the mid-90s and early 2000s, there was a bit of a shift. I'm sure it's a case of parallel evolution, because there's no sort of one paper in the literature that documents this shift.
Excellent. Thank you for that. Dr. O'Grady, I'm going to come back to you for a moment. And, in contrast to an acute laminitis case, you're often being sought, like many of you on the screen, as a second or third option on chronic cases. So what information do you want to see before taking on a case, and what information and diagnostics kind of helps you get the answers you're looking for to move forward?
Well, do you have an hour? That's quite a question. Just to comment with what Dr. Lesser mentioned a little bit ago about acute and chronic, I don't see very many acute cases, but if a laminitis persists over 48 hours to 72 hours, I consider them to be chronic. They don't all necessarily, like some of the metabolic horses, they don't have to displace, but if you haven't changed that, or in other words, arrested that acute onset after 48, 72 hours, I consider them to be chronic. Now, in my practice is by referral or the consulting service. And since the pandemic, I used to travel somewhere every other week, and since the end of February, I've been home, and it's actually been quite nice. I do have some veterinarians in the area that will refer to me, and then I go ahead and I will meet their farrier. I don't do it very much myself anymore. I try and do it with a farrier so we can all learn, and but I'm still responsible for the case. In either case, and especially over the consulting service, when somebody has a case of laminitis, I want to know how long has this been going on, and if it's been going on for 10 months instead of 2 months, it's got a bigger problem. Number two, I want to know the history, what has been going on. And number three, what kind of treatment has it had? And a lot of times these horses are treated by some excellent veterinarians and or farriers, and I'm coming in here and I'm not going to be able to improve much on them. Once we've chatted about it, I got a good history. I want to see some images, and I will also want to see some pictures of the foot. And from the images, I'm going to be able to see, do I have enough structures there such that I can use these structures to rehabilitate the foot? If the disease has advanced to a point where you don't have the necessary structures left, I have no problem at all saying, listen, I'm not your guy. And I really think that you have a poor prognosis here, rather than putting the horse through a lot more discomfort, the owner through a lot more expense, without having some kind of light at the end of the tunnel on the other side. I've kind of been very aware of how I look at the overall welfare of the horse when I start to treat these things. If I go and I do take the case over to consulting service, I want to know who the farrier is, and if he has the skill level, and or he wants to work with somebody else, because sometimes they're intimidated by, somebody has a doctor in front of their name and they can shoot horses or that sort of thing. So once we've established that, and then if I have a conversation with the farrier and I don't feel that he's somebody that I can work with and carry on the case, then I kind of graciously say, I don't think I want to do this. In other words, the bottom line is I want to have a good result when I finish. And I generally do, because a good way to put it is I select my cases at this point in life.
Yeah, understandable. And, there's several of you here today that are both veterinarians and farriers. It's kind of a unique skill set that comes in extremely handy in these cases, because you come at it from a deep knowledge of the horse in general, and then also the therapeutic farriery that you can offer to these cases. So
I have one other point, if I could, just very quickly.
Sure.
There are some times when I put a whole case together and I look at it and I'm still a little, do I really want to do this case? Am I going to have a good result? And if I have a big question mark, the case goes to Andy Parks and I get a second opinion. And sometimes he's the tiebreaker and makes up my mind whether I go see the horse or whether I continue with it. Thank you.
No pressure, Dr. Parks. I want to actually kind of go to Dr. Parks and yourself again, Dr. O'Grady, and say, okay, so say this case does look like something that you want to take on. You and Dr. Parks work often together, so I wanted to throw this one at both of you. That horse is now standing in front of you. What do you do? So what are your first steps? What are you assessing? What moves are you making to now treat this case?
If I see a case for the first time, I'm going to look at the history. I'm going to question the owner to get some of the characteristics of this case from the owner. In other words, what they see on a daily basis, how the horse eats, how the horse moves in the stall. Sometimes it's really important just to, before you take the horse out, go look at it in the stall. See whether it's shifting its weight. See whether the legs are in front of it, whether it's laying down. There's a lot of things that can be gained by that. Opening the door, watch the horse walk out onto the aisle. In other words, his level of pain or his reluctance to even come out. If the horse is ambulatory, I will take sometimes, I'll just walk from a hard surface, just take a couple steps on a soft surface to see how the horse responds to the difference in the footing. I'm going to walk around the horse and I'm going to pay a lot of attention to his feet. Just like Dr. Lesser was talking about, I'm going to look at the coronary bands. I'm going to feel them. I'm going to look at the overall conformation. Does he have a club foot? If he has a club foot, we know that the horse already has a shortening of the muscle tendon unit. And Andy and I have discussed many times saying that horses with club feet, they're some of the hardest ones to treat with laminitis. Is the horse going to have a low heel? Those are going to have some increased tension on the knee flexor tendon. Looking at them from front, is the foot offset to one side? Are the growth rings diverging, in other words, from the lateral side to the medial side rather than front to back like Dr. Lesser was talking about? Because that means that there's excess pressure on the inside of the foot if the growth is less on that side of the horse's foot. I don't pay much attention to the horse's feet, to heat in the horse's feet, sorry about that, but I do pay an awful lot of attention to the pulse. And I pay a lot of attention to the pulse on the lateral side and the medial side. Are they different on one side versus the other? The next day, once you have gone through that, the hoof testers are invaluable for both veterinarians and farriers. Not only to look and see where your focus of pain is or the area where you have pain, you can also use your hoof testers with the pressure to look at the integrity of the hoof. In other words, if you can deform the sole in front of the frog with your hoof testers, you generally have minimal sole depth or less than 15 millimeters. When you palpate the heels, do you have separations there? So there's an awful lot of different things that you can see there. I want to see the horse walk a couple steps, and then I want to see him turn, okay? Because remember that when you're turning, you're torquing the medial lateral side, and a lot of times I want to see him turn each way. You can see a response there. Once I've gone through this, then I'm going to move on to my imaging and the things that have been described before.
Excellent. Dr. Parks?
I'd like to add a little bit, and then I'd like to ask, hear Craig and Mark's thoughts too, actually, about how we watch horses with laminitis move. I certainly don't disagree with anything Steve said, but one of the things that I remember from school, and one of the things I try and get my students to do is to think differently. And so I'm going to recount a story from my own senior year in vet school. Well, senior year, maybe junior year in vet school. And Colonel Hickman, who is a senior veterinarian at university, walked a horse in the room, walked it around the arena a couple of times, and walked it out. And you know, there's a group of students on the side that are all going, "Oh, is it a little lame on the left? Is it a little lame on the right?" And after the horse was out of sight, the colonel turns around and asks us all, which leg had a white sock? And his point was observation. Okay, and I have to admit, that's kind of how I approach lameness now. So one of the things that I watch when I see a horse move with laminitis is how much it bends its knees. I don't even need to watch its feet. I watch how much they bend their knees, and I watch the temporal characteristics of when they bend their knees. So in other words, do they bend and flex them abruptly and then keep it straight in between, or is it smooth? Because really, you know, we all say horses are stiff with laminitis, but what do we really mean? What are we looking for that makes us think they're stiff? And honestly, the most useful piece of information is how they use their knees. How they position their feet will give you stride length. And the other thing I like to see is, I like to see how they land. Because I'm going to use that as a gauge for any of the mechanical solutions that my colleagues here have talked about. Because my goal is always to try and get them after treatment to land flat or slightly heel first. And the reason I bring that up and ask their opinion is because it's been my experience, and others don't always agree, that horses with laminitis often may land on their toes and then put their heels down gingerly. Whereas some other people think that all horses with laminitis are going to land on their heels because they want to protect their toes. But I know when I'm treating them that I want them to land slightly heel first. And if I'm trying to get them to land slightly heel first, it means they weren't landing slightly heel first before I started. So I'd kind of like to hear what the others have to say.
Have at it, Dr. Silverman, Dr. Lesser.
Yeah, one of the things I agree with Andy with that one. I'll notice some horses that are extremely painful will, as they advance moving forward, they will rapidly break up into the side. They'll bend their knees, and they won't even finish rolling from heel to toe. They'll roll from heel, and then they'll lift the leg up and lateral, just to get them out of the way from not finishing that dorsiflexion of the fetlock of the distal limb. So yeah, the way they move is critical, and to establish where you can place load and how you have to modify their feet to achieve some level of comfort for the horse. So watching the move, and of course turning is always, or almost always, a critical factor, because even a horse that you have tweaked to a point where he's reasonably comfortable in a straight line, you go to turn him, and the rotational forces within the foot will just try to, in my mind, tear the laminae apart. So you've got to find some way of accommodating that horse so that he can turn or twist that foot on the ground and do no harm to the weakened structures in there. So all these details of movement are very important. And Dr. Lesser?
I really don't have a lot to add. You know, I think the biggest thing is, you know, we're all seeing it slightly differently, but we need to make sure we see each individual horse as an individual. And, you know, if we're seeing them more action from their knee versus winging a leg out when they move, like you were saying, Dr. Silverman, we need to take all those little things into account for our plan going forward and how to approach this horse for the best solution.
Horses with medial sinking will actually cross their legs sometimes when they're walking.
Yeah, agreed. I'm sorry.
It's like cows with medial coffin bone fractures.
Yeah.
One point on Andy's that I didn't bring up there a minute ago, when I watch a horse walk, and when they do land toe first, and we do see that quite often. And when they land toe first, a laminitic horse, it's basically a bit of a signal to me that we have some shortening of the muscle tendon unit. And I put that right in my treatment plan, because generally I probably say 90% of the time, I'm going to have a little bit of heel elevation on that horse when I'm finished to make that horse land flat or heel first or slightly heel first.
Excellent. Well, thank you all for that. That was great. You know, I want to go back to Dr. Lesser for just a moment, and we've touched on this throughout our discussion so far, and that's the pain factor of this condition. And, you know, unfortunately, these cases are experiencing, I would imagine in most instances with laminitis, quite a bit of pain. And your treatment for that often includes some form of NSAID or non-steroidal anti-inflammatory drug. There's a wide range of analgesics used depending on the hospital and the veterinarian, from phenylbutazone or bute to Tylenol to hydromorphone. We had quite a few of these mentioned in the article, and there's quite a few more. So while they can help manage pain, they can also create new secondary issues with the gut. And I think both Dr. Silverman and Dr. Lesser had alluded to this. And that's especially when you're dealing with a horse that's already prone to ulcers or other gut issues. So Dr. Lesser, can you expound on that a little bit and kind of tell me how you handle those horses, and you do some unique things that kind of cross over into our world in your practice to help manage pain, but also make sure that you're not damaging the gut in the process?
Yeah, so I kind of throw the kitchen sink at horses when it comes to pain management, especially in the acute phase. But it's really horrible when you're working on an acutely laminated course and you send them into colitis, and now you're working on an acutely laminated course in isolation. So wearing Tyvek in the middle of September is never fun. So, you know, I do consider the gut whenever I'm managing these horses. I usually have the horses on some omeprazole, and I've been using a lot of the Platinum Balance product to make sure that we don't go down any of these other paths that I'm concerned with regarding to GI health, especially because I'm very heavy-handed when it comes to anti-inflammatories, because for me, I need to break that pain cycle, and beyond mechanics, my anti-inflammatories usually do the next best job. So yeah, so almost all of my horses are on some sort of probiotic, prebiotic, when I am dealing with them in hospital.
Excellent, thank you. Does anyone have anything else to add to that in terms of your approach when you're treating these horses that are painful?
Yeah.
You go ahead, Mark.
Oh, I was just saying there are times because I am field-based, not hospital-based. There are drip mixtures and other things you can go IV that will help them from a pain management standpoint, but that's pretty complicated to run in the field. I will tend to occasionally cross over non-steroidals and use like Equiox and bute, so I can use less bute and get a little more pain mediation than just bute with something that's a little safer like Equiox. I'll agree with Steve in that you don't want to over-medicate these horses. You don't want to eliminate the pain too much, because that's what keeps them from tearing their feet apart. So you kind of need to know what's happening with these guys, but you also need them not to suffer. So there's a real balancing act there of what's enough.
Right, like everything else with this condition, it's a fine line. So Dr. O'Grady, what were you going to add?
Yeah, I agree with Mark there. I'm the opposite of Dr. Lesser. I'm stingy when it comes to non-steroidals. Sure, from a humane basis, we want to alleviate pain, but we also want to see, number one, allow the horse to be aware of his feet, so he's being cautious rather than take that pain away where he's using his feet more with a compromised area there. The other part of this is that if you use a lot of pain medication, it keeps me from being able to monitor their feet. In other words, are they getting, is my therapy to the feet, which I consider to be very important, is that adequate, or is the horse more comfortable because of the increased medication? The unfortunate part with the ambulatory clinicians is that it's the owner or the client that puts a lot of pressure on him and say, you know, doctor, this horse is not getting any better. So, well, you know, for the client's sake, they're going to add some more medication and more medication. And it gets to the point where, yes, you made the horse more comfortable, but you're doing more damage to his feet by making him want to go out and run a race because he feels pretty good. Does that make sense?
Yeah, it makes sense. And it seems like yet another frustration with treating this condition, as it is such a fine line, and there is the important factor of breaking the pain cycle while also making sure that you can monitor the true state of the horse. So yet another nuance of treating laminitis. And
I'm going to try and break the tie here or whatever.
Go for it.
And that is, you know, we do deal with different populations, and some of ours, we obviously don't see as many because we're not quite as busy, but we see sepsis-related laminitis. And I'm going to go more along the lines of Craig. I'm going to throw a non-steroidal Tylenol and probably, and obviously hydromorphone IM, but we might go as far as ketamine or lidocaine drips. And honestly, in my experience, those aren't enough to hide things that I can't see what's going on in those horses. I wish it was, to be honest with you.
Well, thanks for jumping in as the tiebreaker. Appreciate it. But I'm going to come back to you, actually. So, okay. I want to transition into therapeutic farriery because this is such a crucial part of managing these cases. And we mentioned how time is of the essence a bit earlier, and this is one of the early considerations that needs to be made for laminitis patients. And it's an expertise of everyone here today. But why, Dr. Parks, is it so important to kind of first and foremost include a farrier with expertise on these cases as early as possible to really bring them in as soon as you can?
So I'm going to sort of back up a little bit and say that basically, I think of it as 3 stages, but those stages don't have dates associated with them. So the super acute cases that we've just, Craig and I have just addressed, treating with lots of analgesics. I'm not going to invoke a farrier's skills there very much. So largely, we are going to do things in the hospital that a veterinarian can do, like soft rides, maybe Redden Ultimates, those sorts of things. Some people would do sand stalls. And at that stage, I don't trim them either. So it's minimal involvement of the farrier at that stage. So it's good that they can see the radiographs that you've had from that time later on. Then there's a sort of what I'm going to say the chronic stage, the end stage, where if you've done your job well and nature has favored you, then the animal has recovered to some extent. And Mark mentioned earlier on that these things don't just go away. And so it's a question of living with it. And many of these horses need maintenance, sometimes lifelong maintenance. And that very much falls in the province of the farrier.
Excellent.
And when I talk about the treatment of laminitis, one of the things I like to say is, why does it fail? And one of the reasons it fails is because people think the animal's doing so well that they push the appointments too far apart between the trims and the resetting of the shoes. And that's very much in the domain of the farrier. And I would say that in between those two, there's this period where both groups are working non-intensely equally together. One of the big reasons that this fails is that people fail to maintain their routine appointments, which should normally performed by a farrier. And the other is they ask them to do much too soon. Because some of the more severely horses we've talked about, they take 6 or 9 months to get back, to get everything repaired inside.
That makes so much sense. And, I want to turn to, do you have something to add?
Yeah, one of the points that Andy made, and he said, in the acute state, he didn't trim their feet. And I just want to add one little point there, and I agree with that part, is that if I see a horse, or, what we lecture on is if I see a horse in the acute stage and he has long toes, I'll take that foot, or I'll have somebody take that foot, put it up on a hoof stand, and I'll have them back that toe up to as far as that toe can be backed up. You're not touching the bottom of it, you're not changing anything about it, but what you're doing is you're taking that leverage off the front of the foot from that long toe. And I think that's really helpful.
So I want to follow that up, Steve. Are you taking it from the front? Because I have tried in the past to improve the breakover from the bottom as well as the front. And I am now very, very cautious about removing any of the white line. I want that white line to be as strong as possible because that's what's holding the sole to the wall. Yeah. And so taking it from the front, and so long as I keep the white line intact, I'm fine with. But I have seen disappointing results when I have started to try and put a bevel that starts from the bottom of the foot that starts behind the white line.
I have one that I was talking about the other night when you got the horse hasn't been trimmed or it's been neglected and you got an extremely long toe. I think, you know, backing that toe up or removing some of the toe from the dorsal wall. We're only doing it, you know, down toward the distal border, and we're not going past the white line ever, or the sole wall junction.
So just one extension of this thing about keeping horses in the acute phase. I'd like to know what people do in terms of taking shoes off.
Sure. I'm happy to offer something there.
Please do.
Oh, as far as I feel that first of all, most time I see horses in the chronic phases, just because of where we are and what I do. But regardless with that, I will pretty much always pull the shoe off. I'll take it off one nail at a time. I'll be as gentle as possible, but I want to have control of that foot as much as possible. If there's an existing shoe in place, it is harder for me to selectively place support on that foot and try to achieve some level of comfort and protection for that horse. So I need, in most cases, almost all, I need that shoe out of the way. I also recognize that a lot of these cases that are on fire, that the hoof capsule itself is weak because you've lost some of the strength of the laminar connection, which lends strength to the hoof capsule itself. You have to provide some level of control for the lateral and displacement movement of that capsule, as well as just think about the bottom of the foot. So you need to cast them or glue them, or different kinds of gluing, somehow provide for that hoof capsule not to pancake or displace or collapse on you because you've lost some of the integrity of the cross-linking, for lack of a better term, of the P3, the coffin bone, to the inside of the hoof capsule.
Craig, could I just ask you, do you take shoes off on horses that you suspect might develop sepsis laminitis or in the early stages of it?
I do, but I do, and I immediately, without putting that foot down, I put them into some sort of other mechanic. Because that's my other worry is, am I going to destabilize this whole capsule by removing the shoe that's might be helping it? So I personally do, and I will actually trim these horses some, especially, I'm living in the thoroughbred world. So if it's a horse with long underrun heels and a long toe, sometimes I have to bring those heels back some to give me a nice solid base that's structurally strong enough that can withstand the mechanics. So I do not touch anything over the front part of the sole, anything from ducket stop forward, I definitely do not touch. But for me, it's really important to have a nice solid heel base to handle a lot of the load I'm trying to put on there.
I just raised the question because you can see, if you look in the textbooks, you can see taking the shoes off is controversial. I happen to agree with both Mark and Craig in this issue. And if it's impending, you can do more to the foot with the shoe gone, but there's always the risk that you hurt things in taking it off. So I do this, I take it off the same way Mark does, and I'm sure Craig does, nail at a time kind of thing.
Well, one more point there. I agree with everybody about taking the shoes off, but what we see a lot in ambulatory practice, or because I see a lot of these horses, the clinician will block the feet and take the shoes off, and this is something I am extremely against. Because remember, you have a horse with acute laminitis, compromised lamellae, and they're going to be walking around on this for a couple of hours until the block wears off. And I take shoes off I pull the nails individually like Mark does with a little, nail puller. And if the clinician is not comfortable working around feet and they feel they have to block them, it's just as easy where most horses, if you give them a little sedation, the sedation of your choice, and you work quickly, they'll pick their feet up off the ground long enough to get their shoes off.
Any additional thoughts on that?
Yeah, I'll keep some appliance, a soft ride boot or something like that. I keep an array of them in my truck just for that reason. So I can give them some momentary comfort and distract them in some way so I can get a foot worked on. I agree with Steve entirely. In my earliest years, I remember blocking one or two and recognize now there was a mistake, 25, 30 years later. But yeah, you don't block the feet. It's just terrifying what they can do to themselves in that period of time when you think they're, improved, and they can just tear them up and you have no idea. You don't have an idea if what you did help them or harm them if you block their feet.
Actually, I do know, because I did block a foot and walked it from one barn to the next, and my radiographs from one barn to the next were different. So it really can cause some major issues.
Well, I can go one worse, and I let someone put a horse on a trailer before the block had worn off. That is a really bad thing to do. But thankfully, it's 25, 30 years ago, as you say, Mark. I'm not going to do those things again.
It sounds like we're entering into confessional. This is good. Keep it going. Okay, well, I want to move back to Dr. Silverman for just a moment. That discussion was incredible, and I kind of want to follow up on it a little bit. We've mentioned several things as far as soft rides, ultimate cuffs. There's quite a few different options, like you said, Dr. Silverman, that you keep on your truck. Can you walk us through a couple of these and kind of the nuances of each, when you're going to turn to them and what they do?
Sure. So much of that depends on your history, personal history. If you were trained by Dr. O'Grady, you're going to use one trend. If you were trained by Dr. Redden, you'll use another trend. Depends on who you are, what your experience is, what tools you have in your truck, or what tools you're comfortable using. So I keep soft rides. They're easy for me. I keep various forms of synthetic and leather clogs. But my truck is set up like a farrier truck, so I can bandsaw and cut and modify things and build my own appliances in the field because my truck's that way. The average veterinarian is going to have to pull something out. I mean, how long were lily pads around? As horrible as they may be, they were used for decades and decades as the first line of defense. And we went from there to blue foam, which was, again, almost equally useless, but it's what we had at the time that we can get our hands on. So I think that there are a lot of ways of achieving goals. If I'm working with a farrier, for example, on a remote situation, I don't say, go out and buy the Joe Bob number 3 and use that device on the foot. I say, we're trying to achieve these goals. We're trying to do this and this with the support and the angle, and where we're placing the support. What tools do you have access to in your truck or in your world that we can use to achieve these things? That's more the important focus than the actual toys we have.
Excellent point, per usual.
This is the first time I'm going to disagree with my friend Mark, is that I don't have a certain methodology when I see a horse. If I do see a acute stage, or what we teach is, I think we need to teach each horse, treat each horse as an individual. And when I see a horse, I might do something to the horse, one horse today, and I see another horse that afternoon, I might do something completely different, depending on the circumstances on the horse, the ability of the client to take care of it, the surroundings, that sort of thing. So I don't have one method. I try and be creative and think my way through what is going to be the best for this particular case.
No, I meant as far as your approach, not your tool. I know, for example, you're a fan of clogs. You're not going to use clogs in every horse. But what I was implying is that someone that you trained is going to probably use a similar approach to you as far as how they evaluate a case.
Absolutely. So, one of those approaches, or one of those tools rather, is the wooden shoe. And I want to make sure that we cover the wooden shoe. And I'm going to turn to Dr. O'Grady for this, who has done perhaps more work than most out there with the wooden shoe. So Dr. O'Grady, can you kind of take us through the wooden shoe, when it's used, what the benefits are, and really give us a good understanding of that?
Sure. Just to go back to Mark on the acute stage, if I see the case, I may put a pair of wooden shoes on that horse, the first time I saw it, and there would be no trauma to the foot. I would stand them on it. I would put a couple screws on the outside of the wall and then put some casting tape around it so I can take it on and off to look at the foot. You can also use the wooden shoe. You can put him in ice. You can do whatever you want, but he has something on the mechanical on the bottom of his foot. Okay. I started with the wooden shoe in 2003 when I was asked to evaluate it when it was presented as a paper for AAP, and I started using it, and it was 2 years later when it finally got accepted to get in there. And right now, I've been personally, and that's all I've written on, is we have probably well over 300 cases that we've done. And it's, in all my years as a farrier, it's been one of the most successful option. I'm going to put the word option out that I've had in my hands. Now, if you think about it, and you talk and you hear about all these different things that can be done biomechanical or farrier-wise to a horse with laminitis, there's basically 3 things we can do, no more. And that's redistribute the load, we can change the position of breakover, and we can change the tension in the deep digital flexor tendon. And these are the Farriery principles or the biomechanical principles. The interesting thing is I found that the wooden shoe satisfies all 3 of those principles. And I have to put up in great big letters across the screen, there's a learning curve for putting these on, because you would not believe some of the cases that we see that have had a wooden shoe put on it. And I think for either a vet or a farrier using them, they have to understand the biomechanics of it. And I understand the biomechanics, the aspects of biomechanics only because of Dr. Parks, who's drilled them into my head. But the 3 biomechanical aspects that I outlined, the wooden shoe appears to satisfy all 3 of those points we talked about. Number 2, it's a way of I think the advantage of it is it's one flat surface you're putting against another flat surface, and the block you're putting on there has the 3 biomechanical principles in there. The other really good thing about it is, or the nice thing about it, is atraumatic. The only time you need to maybe sedate a horse, or why I don't block and laminate horses at any time, but the horse may not like the drill when you're drilling holes, or some of the noise that you're using from the tools you use, and you might need a little sedation from that. Okay. And the other thing is that you can, once you put it on, you can walk the horse, you can pick the foot up, you can change it accordingly, you can re-radiograph it, in other words, you can manipulate it until it's happy. And it's very seldom that a case that is selected that we don't get a good result. The other part that I really enjoy, I think that it's probably cut down on my practice and my income a bit, because the amount of tenotomies I've done since I've been using the wooden shoe is probably 75% less than I did before.
Excellent. Well, I sure have the benefit of having veterinarians / farriers on here today, so this is great. I really appreciate the description of that. And I want to transition just a little bit. We've talked a lot about diagnostics, about treatment, about therapeutic farriery, and I want to transition to arguably the most important factor when it comes to laminitis, and that is prevention. And I know that, you know, Dr. Silverman, you said you're better off avoiding a battle than going to battle, because that battle is always uphill in this case. And like you later said, it's like pushing a pebble up a hill with your nose. Can you talk us through prevention a little bit, the importance of it, and some of the steps that you're taking when you might recognize a looming threat of laminitis on a horse in the field?
Sure. Well, from the endocrinopathic standpoint, obviously, body condition is critical. Being aware of a horse, just reading, you know, you can, anybody in this meeting, if you send them a photograph of a good quality photograph of a horse's foot, they can tell you a 2-page story about that horse. They can read the growth lines, they can look at the hairline, they can look at the style of how the foot grows, and they can infer an enormous amount of information on that. So learning to look at a horse well, the great Dr. Moyer taught me as a trainer before I was a vet, that every horse you look at, you know, you should be able to go from nose to tail and from nose to tail on the other side, top to bottom in a few minutes and get a feel for the whole horse. So you need to look at the entire animal. You need to look at, again, the indicators of body fat problems, the growth differences in the feet, how the horse is handling stress in his back, his position of his feet, how he moves. All these things can be little subtle details or indicators of pending problems. As far as laminitic specific growth, some of our clients, if we can convince them, do annual foot balance x-rays. Not as many as I'd like, but some do. There are a lot of things that, if you're used to looking for it, you can see in the x-rays before they hit a critical phase. There are indications you can see within the lamellar zone itself, not the horn and lamellar zone, but the lamellar zone, that will indicate a horse that is a subclinical sinker before he has pain. So you can get a lot of information if you look and take the time to appreciate what the horse is trying to tell you. So that's the biggest thing, I think, is paying attention. As somebody pointed out earlier, the horse that gets sore after every trim, well, either they have a really problematic farrier, which is unlikely, or they have a horse that has a problem that no one's recognizing. You know, you look at the bottom of a horse's foot, and you can tell a lot from the character. Is it a nice cupped structure where you can look at it and pour a cup of water in it and it would hold it? Or is it this thing that's got a very flat sole and you can deform it with your thumbs? You know, and maybe the horse doesn't seem lame, might not even hoof test sore, but you can tell that something's not normal there and start looking deeper. So it's using your skills in a holistic fashion to try to achieve, to read that horse. Does that cover?
That. Yeah, no, it does. And it reminds me of what Dr. Park said about his instructor walking the horse in the room and expecting everyone to actually notice the white sock. You know, it's being an observer. So I like that a lot. I'll open it up to anybody who wants to elaborate too.
Just say one thing on that, and that was a wonderful description by Mark. But if you sum it all up, and I think that one of the biggest problems we have as far as prevention and or complications to treatment is obesity. And I think this is one of the things that we have to get through to the, we're not going to have a cure for laminitis, but we're going to have a way to prevent it. And I think obesity is one of the worst problems that we face today. Would you agree with that, Mark?
Absolutely. Absolutely. I see it all the time, and it's frustrating because it's recreate that. We do this to the horse.
100%. We see it in human medicine as well. I think that number one problem is probably mirrored through both species. I would completely agree with that. And, you know, along those lines, I've had the pleasure and the terrifying experience of being a non-veterinarian interviewing 4 of the kings of laminitis treatment. So thank you for that. I want to ask Dr. Lesser about something I actually might know a tiny bit about selfishly, which is nutrition. And, you know, speaking of obese horses and of recognizing that these horses are oftentimes overfed or fed the wrong feedstuffs or so on, Dr. Lesser, I know you get pretty aggressive in terms of nutrition and making sure that you recognize things early with these horses. And also when you have cases of laminitis in front of you, making the necessary dietary adjustments. So tell me about that a little bit and why it's important.
Yeah, so honestly, it's core to it. The endocrinopathic side of laminitis is what most veterinarians will be seeing the majority of the time, and it's the majority of the cases completely. Getting weight off horses I find is incredibly important. One of the biggest things I do is I give a lot of owners weight tapes, and I have them weight tape their horse and take photos of their horses every week or two. Because since they see their horses every day, a lot of times they won't notice their horse gaining 5 pounds a week, but over the course of a few years, the horse will gain a few hundred pounds, and now they're metabolic. Now we're having issues. So just kind of giving owners the ability to track this progress on their own can be really helpful. Nutrition-wise, yeah, we're looking at our grains. If these horses are retired horses, they probably don't need a lot of concentrates. A lot of times, whether it's just with our hay and maybe a ration balancer on top of that, we'll get them plenty of nutrition that they need. I definitely add in a decent amount of medications to help get this weight off. Like we talked about earlier, we can manage the food side of things, but a lot of times once they've delved into this metabolic world, it's hard to get weight off without the exercise. So really trying to get the food's important, and then getting them comfortable enough to get back into exercise is also really important. And, as veterinarians, I know nutrition wasn't one of our cores, at least in my school. So I do reach out to a lot of my resources in the nutrition world when I'm struggling with cases, and a lot of times refer owners to them to help us figure out what's going to be the best for each individual.
Excellent. Are there any additions to that? Okay. So, I want to move on to, kind of the tough call, frankly. We've done a deep dive on causes, diagnostics, treatments, therapeutic farriery, prevention, nutrition, and now it kind of brings us to the unfortunate but really ever-present fact that when you're dealing with laminitis, a positive outcome is not always possible. And although it's a tough topic, I think it's an important one for us to delve into a little bit, and that's making the hard call on when it's time to say when with the patient. And each of you with me today are all, you're passionate advocates for the horse. And I remember Dr. Silverman, when we were talking, he was making these great points about establishing clear goals from the beginning and making that a priority with the client, especially early on. So you know what you're dealing with in terms of the laminitis case, and also what your goals are and where you're heading. And I know Dr. O'Grady is very passionate about this area also, but Dr. Silverman, let's revisit that conversation a little bit and tell me why it's so important to create these goals in the beginning with the clients, and to make sure really that the right and appropriate goals are being kept in mind for the horse.
Well, importantly, once the horse has reached a chronic phase of this disease, the changes in the feet are permanent. You can manipulate them, you can improve the state of the horse's well-being, but the change in how the foot functions is what he now owns. So if the owner has a situation where this is their only horse, and if this horse can't come back to a previous level of performance, then they don't want him. And you're going to dive this deep dive, as you put it, into therapy on this horse and spend a fortune of their money with them having expectations of getting back to their previous glory, and you're just trying to make the horse comfortable. So you have to have symmetrical expectations. And in the case of a chronic case, more often than not, it's like, are you going to be happy with a horse that is pasture comfortable? Because that's potentially achievable on this horse. If your only happiness is going to be that the horse can jump, 4 feet, then we're not pursuing this to an end that you're going to be happy with. So you have to be clear on what your goals are. And what may be achieved. Anything beyond that, I mean, we've all had horses that have come back to a point where they've gone on and performed at an amazing level, but that's not the norm on these things. The norm is, can you make them so that their life isn't miserable? And unlike you or I, where we can, have some pain and discomfort and still look forward to seeing our kids grow up, they're kind of on a plane where, am I having more good days than bad? If they're having more bad days than good, then, you have to reassess what you're doing for them. For is used loosely in that case. So that's kind of why I want to make it clear up front right away, and we deal with that perspective all the time. And I'll try to guide them along a practical solution. You know, if you look at someone that, we had this conversation, if I have a person who just lost their spouse and their horse is now foundering, I'm like, I'm going to pull out the stops to buy that horse some comfort time so I can separate those two events and not have that person completely crash. That's getting very personal, and it's not my decision to make, but you try to read the situation in the entirety so you can help guide things along. Because people are asking you, what would you do? Or even if they're not asking it, they're implying it. So.
Yeah, I think that's very fair. You're a veterinarian, you're an advocate for the horse, and you're balancing that with being an advocate for the client as well. It's a difficult position to be in. Dr. O'Grady, anything to add to that?
Yeah, I'll go back to, I agree with what Mark said, and I'll go back to Billy Moyer, who's a personal friend, and I was shoeing horses in the Chester County area when he was a resident in New Bolton Center. That's how far back we go. And please don't ask my age, but anyway, or Bill Moyer.
That was my next question. So,
but anyway, he's the one that got me thinking about, you need, if you have a serious case of laminitis, in other words, in the first, at the onset, first day or two, or if you have one with distal displacement, sometimes the owners are left out. And you need, like Mark said, to sit down and have a serious talk with the owner. And in other words, you have a serious situation here. The prognosis is poor, and we don't know the outcome. Number two, we have no consistent, proven treatment for laminitis. Number three, any treatment we do to your horse is going to be prolonged, it's going to be expensive, and again, we don't know the outcome. And in so many times, more than not, the endpoint is euthanasia, because there is a point too where you have to, even if you have to convince the owner to get a second opinion or get him to understand how much the horse is suffering or whatever, to make that decision. But that's something sometimes we often neglect.
100%. Dr. Lesser, Dr. Parks, anything to add?
We probably both have something to say.
Go ahead.
Okay. There's a bunch of different scenarios, so they're not all the same. There's a personal threshold beyond which I really can't stand to watch some horses go through things. And I hope everybody has those. And when owners refuse to stop, that gets very difficult when I can't stand to watch it happen. But the other scenario is the one where owners can't decide which way to go. And I've been a colic surgeon most of my career. And when someone is deciding whether to go to colic surgery, when I think the odds are 50-50, I ask them, and as Steve said, it's going to be expensive. You're going to spend, I don't know, $6,000-8,000 doing colic surgery, and they don't know whether to spend the money, and it's a 50-50. I usually turn around and ask them, and they say, well, what would you do? And I think that's a really unfair question, okay? Because it's an emotional decision. So I turn it around on them and say, well, let's suppose we spend $6,000 on your horse and the horse dies. Will you feel good about you having tried, or will you wish you'd saved the money?
Fair.
And that sometimes works for horses with laminitis too. The nice thing about colics, or not so nice thing, is it's usually all over in, somewhere between 12 and 48 hours, whereas laminitis can last forever. You can manage them. I've managed horses that shouldn't have been managed perhaps, but for years. And so it's all different. Craig, I'm sorry, I butted in.
No, I'm very similar to you all. And, I usually tell them there's three of us involved in this. There's the horse, there's me, and there's you. And whenever one of us says we're done, we're done. And I come to a very firm understanding in the beginning that's how it's going to be. And I may tell them at times that they're not going to be happy when I say we're done, because like we all do, we have to be the advocate for the horse. And I think a lot of horses, you can tell when they're done. There's some pretty tough horses out there, and then there's some thoroughbreds that might not be quite as tough. And seeing some horses can handle it, and I'm willing to put those horses through some suffering as long as we still have that light at the end of the tunnel for a happy life. If this horse is going to be in chronic pain, that's not what our goal is. I need to have a true light at the end of the tunnel to put a horse through some of the more severe cases of laminitis.
I think that, one of the important things for clients to keep in mind, whether it's laminitis or any other emotionally charged situation with their horse, is that they're dealing with a veterinarian that, yes, may see this a lot, and you're doctors, but you're people too, and you are advocates for the horse. And I'm sure it's not a comfortable or desirable situation to be in. So I respect what you all go through in that way as well, because you're right there along with the owner and the horse, going through it step by step. And so thank you for your thoughts on that. I know it's not a happy topic, but I think with laminitis especially, it's one that deserves to be recognized and addressed. And I want to round us out here. We've had an incredible discussion that has been a treat for me. And I want to round us out with not only where we are and where we've come from, which we've covered, but also where we're going. And so I want to point this one at Dr. Parks first and say, what is our hope for the future for laminitis? Dr. O'Grady always has a good point. There's no cure for laminitis. There's a lot of people that certainly wish there was, but we learn more and more as time progresses and research progresses. But where do you see us going, and where do you hope we're going and we're focusing our efforts in the future?
Well, I wish I had a crystal ball, but I don't. I think I told you earlier on that the different entry pathways all have potentially different ways that this can be addressed. I really think that the work that clinicians like Kathy McGowan are doing, and Claire Wiley, who's an equine epidemiologist, are doing, is going to identify risk factors. And so there's maybe things in management that we can do. And certainly increased awareness of and diagnostics of things like equine metabolic syndrome, PPID. And then there's the pharmacological treatment of sepsis induced. And honestly, that's still looking a ways away. Icing is the best. Dr. Pollett's work on the use of ice treatment is the best thing that's come along since I've been doing this, and that's just about 40 years. But I think that's, so there's several avenues because there's different ways into this problem. I'm sort of excited about the prospect of epidemiology identifying the risk factors and helping us eliminate them. But identifying the risk factors means that then we have to get people to actually, not double size their feeds.
Yes, it does. And we included Dr. Byrne, who couldn't join us today, but she was included in the article, and she was saying things like there's work being done on viral vectors, potential gene therapy, things along those lines. Any comment on some of these avenues that are being explored?
They're a little bit beyond me.
If you go back to where we started, no matter whether it's gene therapy or whatever you're thinking about, is think about the tissue that is locked in a box. Okay, we still need to get after that, and that's what makes treatment so hard. So I think our work has to be toward the risk factors like Andy talked about, and various ways of prevention. And again, I can't stress enough the problems with obesity we have in the competition horses, or all horses, versus the athletes.
100%. Absolutely. Well, I'm going to go ahead and thank you all profusely from both myself and from Platinum, and say that this is going to conclude our roundtable on laminitis today. We've covered things top to bottom, and I've had the opportunity to spend a lot of time here with some of the very best And not only are you tremendous veterinarians, but you've each spent and continue to spend your careers, your time, and your tireless efforts on behalf of the horse. I'm so impressed by each of you, really. And thank you for joining me in this discussion. And I encourage everyone watching and listening to visit platinumperformance.com/articles to read the article on laminitis that each of the veterinarians here today contributed to. And again, you all have my extreme appreciation and thanks and admiration for what you do and for taking your time out of your day to spend it with me here. So I want to thank you again for joining us, and for all of you watching and listening, thank you for tuning in. Take care.